Thank you so much, Dr. Grima. At this time, those who are interested to attend the aorta patient and family support breakout session are encouraged to use the separate Zoom link that's being placed in the chat at this time. And this important session will be led by our colleagues Katie Scollin, Elisa Castor, and Ashley Draxinger. So now I'm happy to welcome our next speaker, Dr. Mousumi Moulik. Dr. Moulik is Associate Professor of Pediatrics and Director of Pediatric Cardiovascular Genetics Clinic at UPMC Children's Hospital of Pittsburgh, and we look forward to her talk on the role of genetics in the diagnosis of aortic disease.
Thank you very much. It's an honor to give this talk, and I'm really happy that we are together here in this symposium. So no disclosures, just I do have an NIH R1 grant support. So the goal of my talk is to see what is the role of genetics in the diagnosis of aortic disease. And one important distinction when we start with the genetic diagnosis is to make a distinction between thoracic aortic aneurysms and abdominal aortic aneurysms, and to realize that these are two etiologically distinct disorders. Genetic diagnosis has primary utility in thoracic aortic aneurysm patients, and monogenic susceptibility has been found in about 30% of patients who have thoracic aortic aneurysms. Abdominal aortic aneurysms, on the other hand, are usually degenerative in nature, linked to other comorbidities like atherosclerosis, hyperlipidemia, hypertension, smoking, typically seen in older age group. And even though there's genetic risk susceptibility loci, this is probably some amount of polygenic inheritance. So the rest of the talk is going to be primarily focused on the thoracic aortic disease genetics. The primary pathogenetic mechanism which is seen in thoracic aortic aneurysms is medial degeneration. And this does occur with aging to some extent, but in thoracic aortic aneurysms, there is a huge genetic predisposition and further augmented by other risk factors like hypertension, smoking, hyperlipidemia. Thoracic aortic aneurysms, we can divide them into two groups, syndromic and non-syndromic. And even though syndromic is what we are very familiar with, Marfan, Loeys-Dietz, vascular EDS, they compromise only 5% of the thoracic aortic aneurysm patients. Non-syndromic, they compromise 95%, so that's a huge chunk. And this is the group, the non-syndromic, where there is a huge diagnostic gap. Within the non-syndromic, you have familial non-syndromic TAD, that's around 20%, and 80% are sporadic. The genes which have been identified in syndromic thoracic aortic aneurysms, as well as the familial thoracic aortic, non-syndromic thoracic aortic aneurysms, can be categorized into three primary groups. The first group is the genes which encode extracellular matrix proteins, and the Marfan syndrome gene, FBN1, fibrillin-1, is part of that. And then we have some of the other genes, LOX, which has similar phenotype to Marfan, and collagen 3A1, which is the vascular EDS. These are all part of the extracellular matrix encoding gene category. The next group is the smooth muscle contractile and structural protein genes. And some of the common non-syndromic familial TAD genes, including ACTA2, MYH11, FLNA, PRKG1, they all belong to this group. And then finally, there's a third group, which is the TGF beta signaling pathway genes. and pretty much the lowest Dietz syndrome genes, including the TGF-beta R1, TGF-beta receptor 2, SMAD3, TGF-beta 2, TGF-beta 3. These all belong to the TGF-beta signaling pathway. So one of the questions which can be asked is there a common, final common pathway? When you go look at the extracellular matrix gene proteins, FBN1 mutations with Marfan syndrome, that also has been shown to result in increased TGF-beta signaling. Though we do not understand as well whether the same may be also active in the smooth muscle group or not. And with the TGF-beta signaling being activated in these two groups, that's the biologic rationale behind the beneficial role that angiotensin receptor blockade may play. So looking at some of the common TAD genes and the associated findings, that's one of the roles where genetics can help not only in diagnosis of the syndromic thoracic aortic aneurysm disorders, but also in giving gene-based phenotype correlation and help identify non-cardiovascular features for which the patients may need additional surveillance. An increasingly recognized group of non-syndromic TAD, which is familial, is ACTA2. And it is now getting its own name called ACTA2-pathy, or the familial thoracic aortic aneurysm disorder 6. These patients may have aortic aneurysm, also bicuspid aortic valve, PDA, but they also are prone to premature coronary artery disease. They may have some extra cardiac findings. Livedo reticularis, this is a skin finding where you have some elevated micropapillar spots in the skin. It's very common, and I've seen several of our families where parents have said they have this. Iris flocculi can be present in ACTA2, and then moya can happen. These two findings, the iris flocculi and the livedo reticularis, could be a tip-off that this could be a family with ACTA2. The three other common groups, vascular EDS, Marfan and Marfan-like syndromes, and Loeys-Dietz are the vascular EDS ones. They usually would have a very translucent skin, and additionally easy bruising and joint hypermobility. But the translucent skin is very characteristic of vascular EDS patients. Marfan patients can show a huge phenotypic variable expression. And in addition to the classic Marfan syndrome, where patients will meet the physical score positive of 7 or greater, there could be partial manifestation of the physical score. And that's where genetic diagnosis can play a role in patients who may have partial physical score but also showing aortic dilation. Within the Loeys-Dietz group, there are multiple genes, and especially the TGF-beta receptor 1 and 2, those are the ones which can have a more malignant phenotype and can result in aortic dissection at a much lower size compared to that of Marfan. And the guidelines for intervention for prophylactic intervention on the aorta is there at a lower size. And I'll show that in a subsequent slide, some of the size guidelines, which are gene-based. SMAD3, which is Loeys-Dietz 3, that in addition to aortic aneurysms can also have osteoarthritis. So big chunk is the non-syndromic thoracic aortic aneurysm disorders, and I think that's where it's the key diagnostic challenge, and we have a huge diagnostic gap. The prevalence of TAs is felt to be around 1% of the general population. And 95% of the TADs are non-syndromic. So these patients don't reach preclinical diagnosis based on any kind of extracardiac findings, and they look perfectly normal and healthy. And 95% of the TAD patients, they have no preceding warning symptoms. The first presenting symptom is actually acute death, and in the presence of dissection. And the acute mortality is as high as 50 to 80%. And if patient makes it to the hospital, even the 30-day mortality can be as high as 20%. And it accounts for around 1 to 2% of deaths. And in some autopsy series where coronary CTA has been done in the postmortem, this could be as high as 7%. So we feel that there is probably an underestimation of the incidence of acute death related to non-syndromic TAD dissection. So how do you do the pre-symptomatic diagnosis in these patients? They're not syndromic. They may not have familial warning symptoms. So this is where I think both genetics and a focused risk-based screening would be helpful. This is a screening strategy which has been proposed by Dr. Alaftariadis. This was published in Seminars Thoracic Cardiovascular Surgery in 2019, where in addition to patients who have a family history, and that would account for maybe around 20% of the non-syndromic TAD patients. If there's any presence of renal cysts, if there's bicuspid aortic valve, presence of abdominal aortic aneurysm, bovine aortic arch, and also a lot more flexible, the thumb-palm sign. This is the group which would benefit from some screening for asymptomatic screening for thoracic aortic aneurysms. And then is there genetics diagnosis, I think, is the knight in shining armor here, where it would be able to help identify at-risk family members who have genetic predisposition for thoracic aortic aneurysm. And that would be possible in around 20% of the non-syndromic TAD patients. And in this group, around 30% of patients, a likely causative genetic variant can be identified. Now, when we look at the genes, the three categories that I talked about, these genes, these are overlapping genes associated with both syndromic and non-syndromic. And you can see the ones which are starred. These are the ones which are syndromic, but they can also be found in non-syndromic TAD patients. Now, this one shows, this is a single institution study from the group at Yale. And in their cohort of patients, their standard has been actually whole exome with targeted sequencing analysis for the TAD genes. And the positive yield can be as high as around 30% to even 40% if you include all the syndromic patients too. So do all of these genetically mediated TAs have the same risk for aortic dissection? And that's no. Within this huge group of genes, there have been 11 genes which have been identified to confer a highly penetrant risk for thoracic aortic aneurysm dissection. And these are the FBN1, LOX, vascular EDS, collagen 3A1, some of the smooth muscle genes, as well as the Loeys teeth. Within Loeys teeth, the TGF beta receptor 2 and receptor 1, and SMAD3. Now, genetic diagnosis can also inform the risk for at what size aortic root surgery or a prophylactic surgery for the ascending aorta replacement should be performed, because some of these genes, you cannot wait until the standard guidelines of 5 to 5.5 centimeters. And this is specifically true for some of the TGF-beta genes, as well as the extracellular matrix genes. And then in between comes the ACTA2 and the MYH11. So in summary, the genetic diagnosis, one, it can be predictive of genetic testing. You can do predictive genetic testing in at-risk family members using cascade screening. And that, I think, will help identify probably around 20 to 30% of patients at risk for familial TADs. It also helps establish the diagnosis in syndromic TAD patients with both complete and incomplete physical manifestations, and that accounts for maybe around 5% of these patients, of the overall cohort of TAD patients. And it also helps inform the needs for extracardiac surveillance based on gene-based extracardiac complications. And there is gene-based aortic disease presentation and prognosis, as well as risk for dissection at a given aortic diameter, which is gene-based, and risk for additional vascular diseases. So I feel genetic diagnosis in the current era plays a critical role in the care of patients with thoracic aortic aneurysm disorders. With this, I'll end. Thank you very much.